The management of congenital complete heart block has evolved from a reactive approach to one that emphasizes prenatal risk stratification, pharmacological prevention, and long-term pacing strategies designed to mitigate pacing-induced cardiomyopathy. Antenatal screening and pharmacological prevention. For immune-mediated congenital complete heart block, which is typically associated with a transplacental passage of maternal anti-Rho SSA and anti-La SSPA autoantibodies, management begins early in pregnancy. Surveillance. In pregnancies complicated by positive autoantibodies, serial fetal echocardiography is the standard of care. Monitoring typically occurs weekly or bi-weekly starting from between 16 to 18 weeks and continuing until 28 weeks of gestation to catch early signs of atrioventricular conduction delay. Prevention. Recent retrospective data strongly suggest the use of hydroxychloroquine to prevent the development of congenital complete heart block. Administering hydroxychloroquine prior to conception or early in pregnancy significantly reduces the rate of congenital complete heart block in asymptomatic women with RO-SSA autoantibodies or those with a prior infant affected by neonatal lupus. Fetal intervention for established AV block. Once a fetus progresses to complete third-degree heart block, the condition is generally considered irreversible. Pharmacotherapy focuses on preventing progression in the early stages or managing secondary complications. Corticosteroids. Fluorinated glucocorticoids such as dexamethasone or betamethasone can cross the placenta and are often initiated when first or second degree blocks are detected to reduce immune-mediated myocardial inflammation. However, their routine use is debated due to mixed evidence regarding their ability to resolve established block and the associated maternal and fetal risks, including the potential for impaired fetal neurological development. Beta sympathomimetics. If the fetal ventricular rate drops precipitously, typically below 55 beats per minute, or if hydrops fetalis develops, maternal administration of beta agonists is sometimes used to augment fetal heart rate and cardiac output, though robust standardized protocols are lacking. Postnatal management and pacing criteria. Permanent pacemaker implantation remains definitive therapy with the timing dictated by the patient's age, symptoms, and specific factors. Neonates and infants. Pacing is unequivocally indicated for symptomatic bradycardia, ventricular dysfunction, or a markedly low resting heart rate. For neonates, a rate less than 55 beats per minute or the presence of complex structural heart disease strongly supports early pacing intervention. Adults. While some adults with congenital complete heart block remain asymptomatic and physically active, prophylactic pacing is widely recommended. Unpaced congenital complete heart block carries a high overall mortality rate and a persistent risk of unpredictable, potentially fatal Stokes-Adam attacks. Prophylactic pacing may be considered in asymptomatic patients with any of the following risk factors: mean daytime heart rate less than 50 per minute, pauses greater than 3 times the cycle length of the ventricular escape rhythm, a broad QRS escape rhythm, prolonged QT interval, or complex ventricular ectopy. Long-term pacing strategies. Because infants requiring pacemakers face a lifetime of cardiac pacing, the physical constraints and long-term physiological consequences of the hardware dictate the surgical approach. Epicardial pacing. Due to the small vascular caliber of neonates and infants, typically weighing less than 10 kg, transvenous leads are avoided. Epicardial leads are instead placed surgically via a limited sternotomy or thoracotomy. Preventing pacing-induced cardiomyopathy. There is growing clinical focus on the deleterious effects of chronic right ventricular apical pacing, which induces ventricular dyssynchrony and can lead to dilated cardiomyopathy over time. To counter this, alternative strategies such as cardiac resynchronization therapy, that is biventricular pacing, and conduction system pacing are increasingly considered to preserve physiological ventricular activation in patients requiring lifelong support.